we're going to talk today about breast cancer updates for the internist. We'll briefly touch on some risk factors, screening, diagnosis, and management of early stage breast cancer, as well as some common side effects that you may all see in your clinics with our patients, management of metastatic breast cancer, and then briefly talk about exercise and breast cancer. Typically, actually, breast cancer staging is not something that is very testable because it is so complicated. So we'll actually skip that for this talk today. And if you're ever interested in breast cancer staging, I recommend apps for it because honestly, that's what we use in clinic because there's so many components that go into it. So breast cancer obviously is incredibly common. About 1 in 8 women will develop breast cancer in their lifetime. But still possible to see breast cancer in men, though the incidence is much lower. About 1 in 1,000 men will be diagnosed with breast cancer. Risk factors for breast cancer, there are many, but these are some of the main ones. Female gender, of course, advancing age, a personal or family history of breast, ovarian, colon, or prostate cancer, which brings to mind some genetic syndromes. Genetic mutations, patients who have ductal carcinoma in situ, DCIS, or lobular carcinoma in situ, LCIS, or atypical hyperplasia are more at risk of developing breast cancer. Alcohol use, greater than about 7 drinks per week has been associated with an increased risk of breast cancer. Obesity, likely due to higher levels of estrogen from conversion of fat. Current or recent use of hormonal birth control or menopausal hormones, nulliparity or a first child after the age of 35, which is of course increasingly more common these days, especially among physicians, early menarche or late menopause, and breast density. So of course, screening mammograms highly recommended for detecting breast cancer early. And this we like to see breast cancer diagnosed early because of course it increases the chance of survival. Ultrasound does not replace mammograms for screening because ultrasound cannot image the whole breast at once. Imaging is less clear and we don't see microcalcifications, which can be a sign of concern seen on a mammogram, which would lead us to further imaging. Ultrasound is used sometimes in addition to mammogram to get another view of a potentially concerning area in a breast. And screening, of course, saves lives. On the left, you'll see the size at the bottom of a tumor found just incidentally versus a tumor found at first mammogram, which is significantly smaller. You can see dime versus about quarter sized. And having serial mammograms is important because it is so helpful to see how a lesion changes over time. So the greatest benefit of screening mammograms is from age 50 to 69. Between the ages of 50 and 59, mammograms decrease the risk of dying from breast cancer by about 14%, and by about 33% between the ages of 60 and 69. So the pretty significant decrease in risk of death. Now, when should mammograms be offered? So typically what we recommend is to pick a guideline and follow it. Guidelines from different societies have different recommendations, but in general, we recommend that women start mammograms between the age of 40 and 45. And as you'll see here, 1 in 6 breast cancers actually do occur between the age of 40 and 49. So waiting till 50 is not typically recommended. Incidence for ages 40 to 44 is about 2 times that of patients ages 35 to 39. And so that's where we sort of get this age of 40 to 45 as the sweet spot to begin mammograms. And mammograms should be offered every 1 to 2 years, though annually, coming from a breast oncologist, is preferred. And they should be stopped based on an individualized plan, but typically age 75 or if a life expectancy is less than 7 years. Now, there's a lot of discussion over the years between annual or biennial screening mammograms. There was a retrospective study done at NCI designated cancer centers that looked at about 230 women diagnosed with breast cancer consecutively between the ages of 40 and 84 who were undergoing either annual or biennial screening. The mean age at diagnosis was 62, which is in line with general diagnoses within the population. and 74% were invasive breast cancers, as opposed to those things like DCIS or LCIS that I mentioned before. And baseline characteristics were matched well between the two groups, and annual screening resulted in a smaller tumor size and earlier stage at diagnosis, which is not surprising. So annual screening starting at age 40 actually decreases mortality by about 40%, whereas biennial screening starting at age 50 still decreases mortality, but only by 23%. So obviously, any screening starting at any age is better than no screening overall. A woman who gets breast cancer has about a 71% higher chance of not dying from the disease if she gets yearly mammograms starting at age 40, meaning that by starting the annual mammograms, we are catching these breast cancers at an early and curable stage. And about 100,000 lives will be saved if every woman between the ages of 30 and 39, this was as of the 2009 census, so if those women began undergoing annual mammograms starting at age 40, as if compared to if they had started undergoing biennial mammograms starting at age 50, so 100,000 lives saved. And this takes into, if we look at a compliance rate with these mammograms of about 65%, that still saves about 65,000 lives. And we'll see about 6,000 to 10,000 fewer breast cancer deaths every year in the US with annual screening mammograms. So I just want to point out that there's a lot of discussion about dense breasts, but there's no special screening recommendations for dense breasts. And the definition is just that there's a greater amount of breast and connective tissue compared to fat in the breast. Sometimes you'll see a recommendation to do screening MRIs for these patients, and there is no general recommendation for that. So we still just recommend that these women undergo screening mammograms. A concern surrounding mammograms from some of our patients, and you might even hear it more in your clinics since you're seeing patients who aren't already diagnosed with breast cancer, is how much radiation is associated with a mammogram. And I can assure you that it is exceedingly small, though it is a common concern. The risk of radiation-induced breast cancer from a mammogram, so you get about the same amount of radiation as 2 months of exposure to natural background radiation, just the radiation that we all experience from the natural environment. And the risk of a fatal radiation-induced breast cancer for a woman who starts undergoing annual screening mammograms at age 40 is about 1 in 100,000. So again, there's much more riskier things that we do for general health maintenance than undergoing annual screening mammograms. And there's a much greater potential for benefit than risks associated with mammograms. So how does it work when a patient goes in for a mammogram? So if there's a concern, they will either get a call back, or more commonly these days, things are being reviewed in real time. And so oftentimes, a further ultrasound, even sometimes same-day biopsy can be done for these patients. So for every 1,000 women who undergo screening mammogram, fewer than 100 actually receive the result that they need to undergo further imaging. And then fewer than 20 of those are recommended for biopsy, and 5 are ultimately diagnosed with a cancer. And false positives are decreasing as mammogram technology improves. So after screening, patients often will, so there's screening and diagnostic mammograms. Diagnostic mammograms are similar to screening mammograms, but have more images or more views of the breasts. So you may be called and asked to do a diagnostic mammogram, or oftentimes a diagnostic mammogram and a breast ultrasound. Breast ultrasound, of course, uses sound waves to make images of the breast, and it can help differentiate between liquid-filled cysts or lesions and solid masses. And then breast MRI can sometimes give a more detailed image of more abnormal findings. So I should mention so none of these screening tests are diagnostic. We'll get to diagnosis of breast cancer, but of course that requires tissue, which we obtain via biopsy. So I just want to take a slight tangent here and talk about pregnancy-associated breast cancer. Since breast cancer is becoming more common in breast cancer, not because it's actually becoming more common, but because women are delaying pregnancy, putting themselves into the age range where breast cancer becomes more common. So pregnancy-associated breast cancer is breast cancer diagnosed during pregnancy or within the first year postpartum or anytime during lactation. It is the most common invasive cancer diagnosed during pregnancy, about 1 in 3 to 10,000 pregnancies. And as I said, the incidence is increasing as women are delaying childbearing. So breast imaging can be done during pregnancy and lactation, but it's challenging due to physiologic changes in the breast during this time. Interestingly, it is more common to be hormone receptor negative, so does not express the estrogen or progesterone receptors. An imaging evaluation of a palpable lesion in a pregnant or lactating woman should not be delayed until after pregnancy or after lactation. We can do imaging during these times, and it can be done safely. And luckily, about 80% of these palpable lesions will turn out to be benign. So they should be evaluated, but for the most part, the vast majority will turn out to just be a benign lesion. So during pregnancy, we typically do not recommend regular screening mammograms. Those should be done before or after pregnancy. But if there is a palpable lesion, that should be investigated. And typically, this is different to general populations, but in a pregnant woman, ultrasound actually has the highest sensitivity for diagnosis of breast cancer during pregnancy. And mammogram can be done safely with shielding if further imaging is needed. We do not do MRIs during pregnancy because breast MRIs require gadolinium, and gadolinium is contraindicated during pregnancy. So during lactation, though, as you can imagine, breast density does increase, making imaging more difficult to do and interpret. But there is no contraindication to mammography during lactation. And screening mammograms should not be delayed due to lactation. This is actually in the AACR, radiology guidelines. Though many smaller centers very commonly turn women away, saying that they must complete breastfeeding for 3 to 6 months before screening mammograms can be done. This is incorrect. It needs to be corrected. Luckily, here at Georgetown with the Orisman Breast Center, we do not have that issue, and they commonly do the screening mammograms for our patients who are lactating. It is important to remember to counsel your patients who are lactating to breastfeed or pump just before their mammogram to minimize breast density and increase the sensitivity of the exam. And MRI can be considered in lactating women who are high risk. And that is often guided by our high risk breast center, which is also located in Orisman, and you could refer patients there if there's any questions. So MRI okay for lactating women, not okay during pregnancy because of the gadolinium. Okay, so that was just a little aside because this is, I think, something that we don't learn a lot about and is an important way that you can guide your young female patients. So in terms of diagnosis, typically a core needle biopsy is done. It's a quick procedure. It is uncomfortable, but not typically terribly painful. And fairly safe overall. It's an outpatient procedure. And usually then we get pathology results within the week. So in terms of diagnosis, the most common type of invasive breast cancer is an invasive ductal carcinoma. This makes up about 75% of all breast cancers that are diagnosed. And it starts in the milk ducts of the breast, as you can see on the right, as opposed to an invasive lobular breast carcinoma, which is the second most common type of invasive breast cancer, making up about 5 to 15% of all breast cancers. And that starts in the lobules. So when we have a diagnosis of breast cancer, the first thing that we think about is the hormone receptor status. So these are done by IHC staining, and we look for the estrogen and progesterone receptors. We also look for the HER2 protein, and if the HER2 protein is overexpressed, this is called a HER2 positive breast cancer. So different breast cancer subtypes depend on what we see in terms of these stainings. So hormone receptor positive, HER2 negative breast cancer. This is either expressing ER, so estrogen receptor, and or PR, progesterone receptor, and this makes up about 70% of breast cancers. HER2 positives can be either hormone receptor positive or hormone receptor negative, and they make up about 10 to 15% of breast cancers. And triple negative breast cancers mean that ER, PR, and HER2 are all negative, and that's an additional 10 to 15% of breast cancers. And why are these important is that these guide us in terms of treatment as well as prognosis. So let's talk a little bit about management of early stage breast cancers. So treating it, being diagnosed, then going through treatment and follow-up of a breast cancer is definitely a marathon and not a sprint, okay? So we do walk patients through all steps of this journey, and it is something that treatment takes typically on the order of months of treatment, and then we follow patients in the breast oncology clinic for anywhere from 5 to 10 years, depending on the diagnosis, and then for some patients indefinitely. So in terms of the diagnosis of breast cancer, once a breast cancer is diagnosed by a tissue specimen, we have to decide if we're going to get staging scans or not. Per our guidelines, and we follow the NCCN, the National Comprehensive Cancer Network guidelines, and anyone can look at those, you just need to log in with your email address. Recommendation is to do staging scans only for stage 3 breast cancer. And again, staging is very complicated nowadays. It involves not only size and lymph node status, but also the things like ER and PR, as well as some genomic tests we do. So if you're ever looking for a stage, I do highly recommend just type it into either an app or a computer program and it'll shoot out the stage for you. So for stage 3 patients, we do recommend staging scans to evaluate for metastatic disease. So this involves a CT scan with contrast of the chest, abdomen, and pelvis, and a nuclear medicine bone scan looking for, as I said, metastatic disease. For clinical stage 1 to 2B, we only do additional studies if directed by signs and symptoms. So if a patient is having localized bone pain or we see an elevated alkaline phosphatase, we typically go ahead and do a bone scan looking for bony metastases. If a patient has elevated LFTs or abdominal symptoms or something abnormal on the physical exam, you may end up doing a CT of the abdomen and pelvis, an MRI, or a PET CT, just depending on circumstances. And then, of course, for pulmonary symptoms, we'll get a CT of the chest. Now, we do not routinely do tumor markers for breast cancer. They're not sensitive, they're not specific, they lead to a lot of anxiety, and they are not recommended in terms of US guidelines for breast cancer. So of course, breast cancer is a very overwhelming diagnosis for our patients. So we do take a team-based approach with a multidisciplinary team made up of medical oncologists, the surgeon, the radiation oncologist, definitely the primary care doctors, as you all often know your patients very well, whereas we are coming to them or they're coming to us with a new, very scary diagnosis. So we always appreciate your support. And then we also have a support team, including our nurses, social workers, counselors, who help patients get through this difficult time. So treatment modalities include local therapies. So when I talk about local therapies, I'm referring to surgery and radiation therapy, and then systemic treatment. So our chemotherapy, our hormone therapies, and targeted therapies. So starting with local treatment, so the goal is to remove the entire tumor and sample the axillary nodes. That also gives us information about staging and whether the cancer has spread from the breast to the nodes, lymph nodes under the axilla. Patients can undergo a lumpectomy, which is also sometimes known as breast conserving surgery, or a mastectomy. So what's important to know for patients is that a lumpectomy is almost always followed by radiation, and it has the same survival or same outcomes as patients who undergo a mastectomy. Typically with a mastectomy, if lymph nodes are negative, patients do not require radiation therapy. So there's a kind of a lot of pluses and minuses here, and an involved decision for patients in terms of what type of surgery they're going to pursue. And then, of course, size of the tumor as in relation to size of the breast comes into play, and the breast surgeons help patients with guided decisions in this area. And breast reconstruction can occur at the same time as mastectomy in the vast majority of our patients. And actually, the Women's Health and Cancer Rights Act requires that all health insurance providers and HMOs actually that pay for mastectomy also pay for the reconstruction that can be done. Some patients opt to not undergo reconstruction, and patients have very strong beliefs one way or the other oftentimes on what they would like to pursue. So when a patient is being taken to surgery, they almost always get a sentinel lymph node biopsy. And so what happens is a radioactive dye is injected near the tumor, and it flows through the lymph ducts to the first lymph node or lymph nodes, typically 1 to 4 lymph nodes that receive lymphatic drainage from the tumor. And a pathologist actually views this tissue under a microscope in real time, looking for what looks like cancer, and a decision can then be made whether a full axillary dissection, lymph node dissection, needs to be done. If cancer cells were not found, then it may not be necessary to remove any further lymph nodes. And we want to avoid axillary lymph node dissections whenever possible, whenever it's safe to do so, because axillary lymph node dissections can lead to lymphedema and long-term side effects that, of course, patients want to avoid if possible. So the other side of local treatment is radiation therapy, and this also decreases risk of a local recurrence. And when I say a local recurrence, I mean the breast cancer coming back in the same location. Radiation is almost always done in patients who have undergone a lumpectomy, and it is sometimes done in patients who have undergone a mastectomy. For example, if the tumor is larger than 5 centimeters, or if a patient has positive axillary lymph nodes. So side effects of radiation therapy can include skin irritation and thickening, fatigue during treatment, and lymphedema. So the risk of lymphedema is kind of additive or more than additive if a patient has undergone an axillary lymph node dissection in addition to radiation therapy. Though overall, typically we see much less lymphedema if a patient has just undergone radiation therapy as opposed to an axillary lymph node dissection. And our radiation oncologists are fantastic and very good at managing these side effects like the skin irritation and slight burning sometimes associated with radiation therapy. So on my side, the medical oncology side, we offer often chemotherapy, which are drugs that obviously travel through the entire body, stopping the growth of cancer cells. They kill any microscopic cells, or that's the hope, that may have escaped from the breast and traveled to distant locations. So this reduces the risk of both local and distant or metastatic recurrences. So chemotherapy can be given before surgery, and it's deemed neoadjuvant chemotherapy, or after surgery, we call it adjuvant chemotherapy. And it's not as bad as it looks in movies you may have seen made in the 80s or 90s. Patients should not be vomiting over the toilet for days on end, or really vomiting at all. We have very effective anti-nausea medications these days, and I'm referring to for breast cancer therapies here. So our chemotherapy, though strong, is typically really well managed in terms of nausea medications. And many of my patients end up working throughout their chemotherapy, maybe taking a day off here or there for fatigue. So that's fairly variable in terms of how people want to proceed. But, you know, some people decide to work the whole time. And then we do use what are called some genomic tests that help clarify the role of chemotherapy and whether there's a benefit to chemotherapy in patients with hormone receptor positive, HER2 negative breast cancer. And just to touch on that a little bit more, just so you're familiar with the names that may be thrown around, we have a test called Oncotype and Mammogram. Those are the two most widely used genomic assays, and they're used only in early stage hormone receptor positive, HER2 negative, lymph node negative breast cancer. Typically for tumors ranging from the size of 5 millimeters, because less than 5 millimeters, we almost never offer chemotherapy anyway. So I'm only going to send a test off, right, if it's going to change my management. So less than 5 millimeters, I typically do not ask for this test to be sent. up to tumors about 5 centimeters. Again, these are the size tumors that were included in the large trials looking at these studies. And over 5 centimeters, we'd start to be a little bit concerned if we were not giving chemotherapy anyway. And so these tests actually look at the tumor themselves and determines the risk of recurrence and the benefit derived from chemotherapy. A tumor is sent to one of these companies, and the genes within the tumor itself are analyzed. Oncotype uses 21 genes, Mammoprint uses 70, and they're very well validated in tens of thousands of women. So we get a score, and it helps us have an informed discussion with the patient about whether we should pursue just endocrine therapy or whether chemotherapy is indicated. So endocrine therapy, sometimes used in conjunction, or I should say after chemotherapy, or sometimes used instead of chemotherapy, again, depending on the characteristics of the tumor and results of tests like those Oncotype or Mammoprint tests. Endocrine therapy are oral medications. They're taken once daily for 5 to 10 years, depending on the characteristics of the tumor and the patient. They reduce the risk of local and distant recurrence. And side effects that are common to both types of endocrine therapy. So we have 2 main types, Tamoxifen and aromatase inhibitors, which I abbreviated as AIs here. So these can cause joint aches, hot flashes, sexual dysfunction, things like vaginal dryness and decreased libido, hair thinning, depression, and weight gain. The weight gain typically is only mild, and it's mostly due to inducing or deepening menopause. So these are things that you may hear from our patients who you follow in your clinics. And we'll talk a little bit about maybe how to manage some of these side effects. And I mentioned the weight gain because that's, of course, very concerning to people, but it is typically mild, and we really can't blame the 20 or 30 pound weight gain, unfortunately, just on these medications. So Tamoxifen is one of these medications. It's a selective estrogen receptor modulator, or SERM, and it blocks the estrogen receptor. It can be used in pre or postmenopausal women, though we typically use it in premenopausal women. It does have some unique side effects that are different than aromatase inhibitors in that it can increase the risk of DVT or stroke, so I would not use it in a patient who has had either of these. It has a small increased risk of endometrial cancer, though these are cancers that are typically early and early stage and caught early. I do recommend to all my patients on Tamoxifen that they continue undergoing yearly gynecologic exams with their OBGYN. And it has a small incidence of cataracts. So if there's any patients who are complaining of any change in their vision, we get them over to ophthalmology. So these are all concerning side effects, though the incidence is very low, but because they're significant, I always discuss them with all of our patients. On the other hand, we have aromatase inhibitors, and the 3 AIs are letrozole, anastrozole, and exemestane. And these block the conversion of hormones to estrogen within the body. And these drugs are only effective in postmenopausal women. So we do not use these in premenopausal women, as it would just be like taking a sugar pill. Though sometimes we convert a premenopausal patient into a postmenopausal patient by giving them drugs that cause ovarian suppression, things like Lupron or Gaserelin that shut down the ovaries. The aromatase inhibitors, based on large data sets, are slightly more effective than Tamoxifen at reducing the risk of breast cancer recurrence. So in a premenopausal patient with a very high risk breast cancer, that's the time that we may use these ovarian suppression drugs so that we can then start an aromatase inhibitor. Now, unlike Tamoxifen, they cause more joint aches than Tamoxifen does. It feels like arthritis to patients, but no actual joint damage is occurring. So once the aromatase inhibitor is stopped at the end of their treatment course, these symptoms typically resolve. So that is something helpful that we can counsel patients about. So although it feels like arthritis, and sometimes there is concurrent arthritis, so that is difficult to tease apart, but that there's no joint damage occurring is helpful for them to know. And oftentimes if I have a patient who's having a lot of joint aches, we get our oncology rehab doctors who are at Georgetown to also help with exercises and different things to help minimize this. And they can cause decreased bone mineral density, so leading to osteopenia and osteoporosis. So we always get a baseline DEXA scan and then follow it every 1 to 2 years while they're on therapy. Moving to HER2 targeted therapy, these also, because they're systemic therapies, decrease the risk of local and distant recurrence. And the 2 drugs most typically used are trastuzumab and pertuzumab, which are monoclonal antibodies that bind to the HER2 new receptor, and they block growth signals and decrease cell proliferation. And pertuzumab is added to trastuzumab for our higher risk HER2 positive breast cancer patients. In the past couple years, trastuzumab and Tamsuine, or TDM1, was approved for patients who have residual disease in the breast or axilla after they've received neoadjuvant therapy for a HER2 positive breast cancer. And so this is an antibody drug conjugate. It's actually too toxic on its own, the Tamsuine, but it's linked to trastuzumab, which delivers this targeted therapy directly to HER2 targeted cells. So you're getting this very potent drug directly into the cells that you want to target. Patients who are on HER2 targeted therapy, one of the important things to remember is that we monitor echoes every 3 months because these drugs can cause heart failure. And if we stop the medications in time, oftentimes patients recover. So we are very, very diligent about monitoring these echoes. Okay, to walk our way through treatment a little bit, this is for our hormone receptor positive, HER2 negative patient. And again, we're only talking about early stage curable breast cancer at this point. So for these patients, we either give adjuvant chemotherapy. So we start with surgery, followed by chemotherapy. And the decision about chemotherapy is made based on that genomic assay that we talked about before, the oncotype or the mammogram. Chemotherapy, if it's given, lasts anywhere from 3 to 6 months, depending on the regimen chosen. Patients then undergo about 5 to 6 weeks of radiation, and then they're on one of those endocrine therapies for anywhere from 5 to 10 years. And then the last thing on the right there is a targeted therapy. There was a recent trial where something called a CDK4/6 inhibitor just showed about maybe 2 months ago at this point, a positive outcome in very high risk breast cancer patients, but not something to worry about right now. For our HER2 positive patients, the decision about how to proceed with treatment depends on the size of the tumor. So if a tumor is greater than 2 centimeters, we start talking about neoadjuvant chemotherapy with HER2 targeted therapy to try to shrink that tumor down before we get to surgery. If it's a small tumor, less than 2 centimeters, oftentimes we'll go straight to surgery and then give chemotherapy with the HER2 targeted therapy after surgery. Patients will still undergo radiation. This is if they have had a lumpectomy. And then patients receive a full year of HER2 targeted therapy. So the HER2 targeted therapy that they received in combo with the chemotherapy counts. So we complete a year of that therapy. And then if they're hormone receptor positive, they also are offered endocrine therapy as well. And then triple negative breast cancer. So these are our patients that are ER, PR, and HER2 negative. We almost always treat with neoadjuvant chemotherapy. So we give chemotherapy for about 6 months usually before surgery. And the reason that we do it before is it gives us a really good idea about the biology of the tumor. Triple negative breast cancers are typically more aggressive, but they also are fairly chemosensitive. So we give the chemotherapy and I'm able to follow the size of the tumor as it shrinks while giving chemotherapy by seeing the patients in clinic about every 2 weeks, doing the physical exam and monitoring. I actually measure it with a tape measure to keep an eye on the tumor and make sure that it is shrinking. So that gives us a good idea about the biology and the aggressiveness of a tumor. If by chance we see that the tumor is not responding to chemotherapy, then we're able to rush the patient to surgery, do the radiation, and then talk about whether we give chemotherapy on the back end. If at the time of surgery there's residual disease in the breast, so not all of the breast cancer melted away, then we are able to give 6 months of an oral chemotherapy that reduces the risk of the breast cancer coming back. So that's why we like to give this chemotherapy neoadjuvantly as opposed to adjuvantly. It gives us more information. And then in the past few years, we've learned more about giving adjuvant bisphosphonates. So of course, you all use these all the time, I'm sure, in clinic for osteoporosis patients. And in our breast cancer patients, it's sort of a twofer in that we've learned that adjuvant bisphosphonates in postmenopausal women actually decrease the risk of breast cancer recurrence. So we see a decrease of bone recurrence by about 28%, decrease in breast cancer specific mortality by about 18%, and an absolute benefit of 2 to 3% in terms of breast cancer mortality. So though, of course, the surgery, radiation, chemotherapy, if indicated, and endocrine therapy get you more bang for your buck, this is sort of an insurance policy to decrease the risk of breast cancer recurrence, which is how I explain it to patients. I typically only offer it in stage 2 or 3 patients, as those are the higher risk for recurrence. Though, since our patients are often receiving an aromatase inhibitor, which causes osteopenia, osteoporosis, again, you kind of get that twofer benefit. So in terms of following patients who have completed their breast cancer treatment, we do not recommend the following for asymptomatic patients if we're following US guidelines. So we do not routinely check labs on these patients. We certainly do not check tumor markers. Neither labs nor tumor markers have been shown to diagnose a recurrence earlier, and they lead to a lot of anxiety for patients. So what I tell my patients is that I want all of my patients following with a primary care physician, and see things like CBC and lipid panels, chemistry panels, should be checked for general health purposes as recommended by you all, and not for breast cancer purposes. Excuse me. We do not follow with breast MRIs afterward. I continue doing the diagnostic mammograms for patients. Breast MRI would only be if we had a concern about something specific. And we do not do imaging surveillance systemically, so no CTs or PET scans for patients. None of these things have been shown to improve outcomes from breast cancer. What we do recommend is yearly mammograms, so yearly diagnostic mammograms if a patient, and so I do say diagnostic because our imaging center at Orrisman will call you back and ask you to change typically a screening mammogram to a diagnostic mammogram in patients who have a history of breast cancer. So if your patient did not have a bilateral mastectomy, then go ahead and order that yearly mammogram, or we can work together to decide who is ordering it. And a periodic assessment of family history and a genetic counseling referral. We monitor and educate patients regarding lymphedema because there are lymphedema clinics available, and they can help manage these side effects. If a patient is on tamoxifen and they still have a uterus, then we recommend annual gynecologic exams. And as I said, periodic bone density or DEXA scans if on an aromatase inhibitor. Definitely most patients who are on ovarian suppression or have had ovarian failure from the chemotherapy, so chemotherapy can cause people to go into early menopause, then we do also monitor DEXA scans. And then we talk and encourage adherence to endocrine therapy because, of course, a medication is only as effective as how often you're taking it. So I do want to touch a little bit on exercise and breast cancer because exercise is great for both primary and secondary prevention of breast cancer. And it's something easy to counsel patients on, though less easy to actually take up an exercise regimen. It has been shown to have a 20 to 30% absolute risk reduction in breast cancer diagnosis in case control and cohort studies looking at exercise and breast cancer. There does seem to be a dose response, so time and intensity relationship. The Nurses' Health Study, which looked at about 3,000 female nurses diagnosed with early stage breast cancer, found that the greatest benefit was in women who walked 3 to 5 hours per week at an average pace. So these patients don't need to be going to a CrossFit gym or doing Orange Theory or whatever, but staying active, well, of course, good for so many health benefits. Also, I tend to talk to patients about this because It's sort of just an extra incentive to get patients out there and exercising. So that study showed about a 6% absolute mortality risk reduction, which is pretty fantastic for something that we should all be doing and practicing what we preach, though easier said than done. So I want to talk about side effect management because this is something that we, as a breast medical oncologist, is so important to have teamwork with you all to help us manage these side effects, because we're seeing the same patients, and oftentimes you all have a very good and established relationship with these patients. So endocrine therapy, oftentimes a lot of the side effects can be managed with acupuncture, which is difficult during a global pandemic. But I know that we have some ability to do acupuncture here at Georgetown. And then typically I can also refer out to the community, though not right now during the pandemic. There are randomized controlled trials showing improvement in hot flashes and joint aches. And they can help patients avoid further medication. So oftentimes my patients hate managing side effects with more medication. Hot flash management, of course, hot flashes can be debilitating for patients. So I talk about avoiding spicy foods and alcohol. Here, acupuncture can be very helpful. Venlafaxine or Effexor is a good choice, especially if concurrent depression. I have a lot of patients who have their hot flashes well controlled using venlafaxine. They usually start at 75 milligrams. If they're still having hot flashes after about 2 weeks, then we can go up to 150. Gabapentin, especially if there's concurrent insomnia, and oxybutynin can also be used to control hot flashes. Joint aches are very common. Exercise, #1 thing to help manage these. The more patients are moving, the less the joints ache. And reassurance that damage is not actually occurring. And again, acupuncture is helpful. And then of course, NSAIDs and heat therapy can be helpful, as well as referring to our oncology rehab colleagues. Bone density management. Oftentimes your medical oncologist will handle it, but again, working together is always helpful to make sure that these things aren't falling through the cracks. So we want to do baseline DEXA scans for our patients on aromatase inhibitors, and then every 1 to 2 years. Prevention is of course important, weight-bearing impact exercises, and recommending calcium and vitamin D for patients. And then if a patient does have osteoporosis or a high FRAX score, then bisphosphonates or medications like denosumab. And again, we really appreciate your help with some of this because oftentimes our cancer appointments are really busy. And so if there's one thing that, one less thing that we need to discuss in these quick appointments, or we can co-manage these things, then that's really helpful. Okay, we are going to just very briefly touch on the management of metastatic breast cancer. So when we're evaluating a patient for metastatic breast cancer, though we check lab tests to look at the CBC and the CMP, labs are not diagnostic of metastatic breast cancer, and tumor markers do not diagnose metastatic breast cancer. We do get either a CT scan of the whole body in conjunction with a nuclear medicine bone scan, or a PET CT with a diagnostic CT. And biopsy must be done to confirm metastatic breast cancer. Occasionally out in the community, older oncologists won't always get a biopsy to confirm metastatic disease, but as a group here at Georgetown, we always get a biopsy because you can be fooled. There could be some sort of lytic lesion that turns out to be something else, and the last thing you want to do is treat someone with a chemotherapy that is not indicated for what they have. So I'm a big proponent of getting that biopsy if at all feasible. Treatment of metastatic breast cancer, we typically do not do or offer surgery or radiation except for palliation of symptoms, as there are large studies showing that these do not improve survival. And as you can think about it, we would have to pause systemic therapy in order to allow a patient to undergo surgery or radiation and then recover from these. So these doing these local therapies can actually worsen outcomes. And of course, we need to be mindful to balance quantity and quality of life in our metastatic patients. In patients who have bone metastases, patients should almost always be on a bisphosphonate or a RANKL inhibitor. And these prevent or delay skeletal related events and can improve cancer pain. And we dose these every 3 months. Again, older outside Physicians you may see it every month, but more recent studies have shown that every 3 months is adequate, and then patients don't need to come in as often, and there's fewer potential for side effects from these drugs. And then, of course, clinical trials. We have many clinical trials for metastatic breast cancer patients at Georgetown, and that's kind of the beauty of being here, is that we can offer standard of care and then also mix in clinical trials when appropriate for patients. So if a patient has a hormone receptor positive, HER2 negative breast cancer, we almost always start with oral endocrine therapies. This is better for quality of life for patients. They don't need to come into the infusion center to get these. They can take them at home and then see us in clinic every month or two. So that's just really good for quality of life. Typically, eventually, patients with hormone receptor positive, HER2 negative breast cancer become endocrine therapy resistant, and they will eventually require chemotherapy. Though we try to hold off. Oftentimes, patients make it a few years before they require chemotherapy. For HER2 positive patients, the treatment is almost always chemotherapy plus a HER2 targeted therapy. And then after about 6 to 10 cycles of the combination there, we're able to get rid of the chemotherapy portion and then do maintenance with a HER2 targeted therapy, which is much easier on patients. The HER2 targeted therapies have very minimal side effects, and patients feel really well. With triple negative metastatic breast cancer, unfortunately, currently the only systemic therapy we have to offer are chemotherapies. And we typically give one chemotherapy at a time until it is either intolerable, the patient's not tolerating it well, or their disease progresses. We don't usually give multiple chemotherapies at once in the metastatic setting for triple negative breast cancer. Okay, so take home message, in terms of working together, partnering between the PCP and us as breast medical oncologists, really want to encourage patients to get their mammograms. If you can encourage yearly screening mammograms starting at age 40, that is fantastic. Though sometimes it takes some easing into for patients. So of course, any screening is better than no screening. And so whenever you can get them in to start their mammograms, that is fantastic. And then hopefully things are always caught early and they're curable and they see us and things go well. Diagnosing breast cancer early, as I'm saying, saves lives. And then endocrine therapies, they must be taken for 5 to 10 years for patients and of course can cause side effects. But these side effects can often be managed. So again, here's a good area that the oncologist and the primary care physician can partner to help manage these side effects and provide support for patients to get through this time. And we're always happy to, be reached by email and chat back and forth about ways to best manage these things for our patients.